السلام عليكم ورحمة الله. الصلاة والسلام على سيدنا محمد وعلى آله وصحبه ومن والاه. We'll start our first lecture today with Dr. Eman. Dr. Eman, she's Eman Bouhamra from Kuwait. She's working in مستشفى الأميري في الكويت. She's the head of the department of pediatric gastro. And we like Dr. Eman to come for her lectures. Welcome, Dr. Eman.
I would like to thank the organizing committee for giving me this opportunity to be among the speakers in this important conference. We will talk about genetic causes of neonatal cholestasis. So the objective of my talk will be neonatal cholestasis with its different causes, and we will concentrate on the genetic causes, and basically we will focus on two clinical entities which we see in our clinical practice in this part of the world, namely PFIC and Alagille syndrome. And we will go over an overview, clinical challenges, management strategies for each of them. So starting with the definition of neonatal cholestasis, it is conjugated hyperbilirubinemia that is present at birth or in the first 2 to 3 months of life. It results from diminished bile formation or excretion, and worldwide, biliary atresia is the leading cause for neonatal cholestasis. And later on in the talk, we will see that it is totally different from this part of the world. Bile formation is a function of the liver, and the bile contains so many components. The major one is water, and it contains also electrolytes, bile salts, phospholipids, cholesterol, and bilirubin. And the bile flow is important for the normal mechanism of digestion and absorption of different nutrients and the elimination of different toxins from the body. The causes of neonatal cholestasis, it can be caused by intrahepatic disease, which can be hepatocytic which can be hepatocyte injury or bile duct injury, and it can be caused by extrahepatic disease, which is basically biliary atresia or any other structural anomaly which causes obstruction. As you see from this slide, it is an extensive list of causes, but we are concerned about the genetic part of it. Generally speaking, if you exclude infections, we can say all of them are genetically determined, right? But we are focusing on genetic causes which are caused by specific mutations, and to be more specific, we will concentrate on two entities for the sake of time. So starting with PFIC, it is progressive familial intrahepatic cholestasis. It is a very serious disease, presents in early infancy, causes progressive liver disease and hepatic failure requiring liver transplantation. It is an autosomal recessive, which means that both parents are carriers, and we have 25% chance of the children to be affected and 50% chance to be carriers like their parents. The main problems are that we have in the hepatocytes in the canalicular wall, we have different transporters for bile acids and phospholipid. So if we have problem with ATP-AB1 for bile salts, then we will have PFIC1. If we have problem with the ABCB11 up, then we will have PFIC2. If we have problem with ABCB4 for phospholipid transport, then we have PFIC3. And just recently, there is a mutation found in the TGB2 in the tight junction, which causes a new form of cholestasis. So this is a summary about the different 4 types. PFIC3 is the only one with high gamma GT. The others are all low gamma GT. And PFIC2 and 3 are confined to the liver, while 1 and TGB2 have extrahepatic manifestations. PFIC1 and 2 and 3 are associated with adult form of the disease. Some of them are minor, but PFIC3 also is associated with intrahepatic cholestasis of pregnancy and gallstones. There is also, in 2016, a paper regarding a new mutation in the fixer gene, and it causes also low gamma GT cholestasis with high alpha-fetoprotein and vitamin K independent coagulopathy. The clinical challenges that we face in the clinic with these patients are many, but I highlighted pruritus because it's the major complaint from the patients, and we will talk about it in more details. And we have also growth failure, asthma-like disease, fat-soluble vitamin deficiencies, and others. And we have also risk of malignancy, specifically with PFIC2. The pruritus is often not proportionate to the jaundice, so the jaundice is coming on and off, but the pruritus is not proportionate to it. Neonates usually manifest as irritability, poor sleep, and the itching doesn't respond well to medications, unfortunately, and interferes with normal activities for older children. So the treatment is medical versus surgical regarding pruritus. If we talk about the medical, it's mainly different modalities of drugs that we are using, like ursodeoxyfolic acid, cholestyramine, antihistamine, rifampicin, and just recently, maralixabat was described, and this was in the AASLD in 2017, and the action behind it is to inhibit the enterohepatic circulation by inhibiting the apical sodium-dependent bile acid transporter. So they had two studies presented, one on Alagille syndrome patients from Schneider group. They divided their patients into placebo group and the medication group, and they assessed the pruritus according to two scales of itching, itch-RO scale and clinician-reported scratch scale. And they concluded that the degree of pruritus has been diminished over the 13 weeks of the study in the medication arm. The other study was a multi-center study for PFIC patients, and it's the same. They just changed the medication dose in 13 weeks, and they concluded also that at 48 weeks, there was improvement in the pruritus, and PFIC2 patients were the one in advantage. Regarding surgical intervention, we have different surgical modalities, starting with the first one, which is partial external biliary diversion, and it is mainly interrupting the enterohepatic circulation by diverting the bile from the gallbladder directly into the skin by a stoma, and it is beneficial before the development of fibrosis. Mainly is used for PFIC1. This paper showed long-term outcomes of 6 patients after this procedure, and it concluded that it is effective procedure in the long term, and it delays the need of liver transplantation. The second one is the ileal exclusion, where they exclude the distal 15% of the ileum by skipping it through ileocolonic anastomosis, and they found that post-op, patients will have no diarrhea, they will have relief of pruritus and normalization of bilirubin level. However, these patients require supplementation of B12, vitamin B12 and folic acid, and they have 50% relapse of cholestasis and symptoms that they might need to convert into the external diversion. So it is not effective as the external diversion. The third one is partial internal biliary diversion, and it is basically diverting the bile from the gallbladder to the colon, but there is a potential of having diarrhea from this procedure. Post-transplantation, so all of them will require transplant eventually, but post-transplant in PFIC2 and 3, the results are very good. PFIC2, however, they will have problems with recurrence of the disease or high risk of hepatocellular carcinoma that need to be monitored with alpha-fetoprotein and ultrasounds every 6 months. For PFIC1, the results are not that good. It is because it affects so many organs. So after transplant, they have a lot of problems as seen in this slide, but the main two are watery diarrhea and steatosis. And just recently, a paper published showing a novel approach where they used total internal biliary diversion at the time of transplant. And what they did, that they connected the bile duct of the graft to the colon directly. And they found that it reduces the diarrhea and it stops the progression of hepatosteatosis as seen here. So day 0 this is the day of transplant, and day 138 after transplant, they did 2 liver biopsies to compare the steatosis. And as you see here in the special stains, there is no difference. Now, what is the local experience in GCC? Talking about Kuwait, we have 3 pediatric centers. We have a total of 44 patients based on clinical presentation and gene study, 2 patients with external diversion, and they are waiting for liver transplantation, and they are all above 15 years of age now. They did the external diversion the first 2 years of life, and 9 post-transplant patients. The majority is PFIC2, 55%. In Saudi Arabia, there was a study from the Royal Military Hospital in 2009. It showed that inherited liver disease is the most common cause of cholestasis and the indication for liver transplantation. And the large majority of these patients is PFIC. There is unpublished data from King Faisal Hospital with a retrospective study from 2000 to 2012. They have 48 patients of PFIC also diagnosed on clinical presentation and gene study, and 1/3 of them required transplantation. And it's similar study to ours, like 76% PFIC too. In Oman, there was a retrospective study from the Royal Hospital of Muscat, and they had 79 patients, and they have more than 50% of the patients are due to congenital causes of hepatic of cholestasis, and 30% of them were PFIC. And also they recorded high percentage of consanguinity, up to 78%. Now, shifting gears to Alagille syndrome, it is described by Daniel Alagille in 1969, and it is also known as arteriohepatic dysplasia or syndromic biliary hypoplasia. It affects approximately 1 in 30,000 live births. It is caused by a mutation either in JAG1 in 94% of patients or NOTCH2 in 1 to 2%. It is autosomal dominant compared to PFIC, so it means that there is 50% chance of having the disease. Now, it is a multi-system disease, so it affects so many organs. It has a special phases, so if we look into the center picture, we can see the typical Alagille faces with a triangular face, straight nose, deep-seated eyes. And if we look into the one in the corner, it has eye manifestation like posterior imperiotoxin. Heart defects, the most common is peripheral pulmonary stenosis. Renal defects in the form of horseshoe kidney and others. Skeletal in the form of hemivertebrates and others. Vascular anomalies, and paucity of bile ducts in the liver. To diagnose Alagille, we should have paucity of bile ducts plus 3 of the 5 criteria mentioned. The clinical challenges for Alagille is almost similar to PFIC. However, we can add on this xanthomas here and intracranial bleeds with renal disease. So if we talk about the management of liver issues first versus other systems, for the liver, still we are talking about medical management and surgical management. And for the medical, it's the same correction of vitamin deficiencies, high caloric formulas, high MCT content, and the pruritus also is a major component, and this is why we are using the same. And I just mentioned earlier the evidence about Alagille patients. Regarding surgical, if we see the partial external biliary diversion, it is not as good as PFIC patients in Alagille syndrome. Regarding the partial internal biliary diversion, it doesn't appear to prevent the progression of the liver disease. Liver transplant maybe is the best choice. It is 15% of patients requiring liver transplant, and the 5-year survival rate is 80%. And the main indications for liver transplant in Alagille is progressive hepatic dysfunction, severe portal hypertension, intractable pruritus, and others. Going to other systems, because as hepatologists, sometimes we forget the other systems, and we should look really into these things and keep an eye on them. Pancreatic insufficiency found in 30 to 40% of children with Alagille, and this contributes to the poor growth and nutrition. So this is treated by pancreatic supplements. Xanthomas usually are disfiguring, and they can restrict the activities depending on where they are. Usually they are in the elbows, ankles, knees, and diaper area, and they improve with liver transplant, as we see in the picture. So as you go across the screen, you can see just before transplant, and then 8 months after transplant, and then 20 months, and you can see the improvement in xanthomas. Regarding renal disease, it occurs in 40 to 50% of children with Alagille, and the list is extensive, but we are concerned about the renal tubular acidosis. Most of these diseases, they don't cause renal failure. However, the renal tubular acidosis can be a potential contributor to the poor growth of Alagille syndrome. Regarding vascular anomalies, which not commonly mentioned, it is mainly intracranial bleeds. It is a major cause of morbidity and mortality. It occurs in 15% of patients. 30 to 50% are fatal, and usually they are spontaneous. Some of them will happen with minor injury. It doesn't only occur in the brain, but sometimes it occurs in other major vessels like the kidneys and the aorta. In some centers, actually, they do baseline MRI brain for patients on the time of diagnosis with Alagille. Regarding growth failure, it is very common in Alagille, and the possible causes are fat malabsorption, insufficient caloric intake, associated cardiac or renal disease, and the gene defect itself, JAG1, has been contributed to growth failure. What about our local experience? In Kuwait, we had a total of 16 patients. All are genetically tested, one with external diversion, still waiting for transplant, and 3 post-transplant. Unfortunately, I didn't find any data regarding the other GCC countries. So the take-home message is genetic causes of neonatal cholestasis is very common in this part of the world. A major etiological factor is high consanguinity rate, and liver transplant is the treatment of choice in most of these conditions. Thank you.